Well, hello there, everyone. I'm Dr. Leslie Kernisan, board-certified geriatrician and the founder of the website betterhealthwhileaging.net. And this is the Better Health While Aging video podcast, where we discuss common health problems that affect people over age 60 and the best ways to prevent and manage those problems. We also often address common concerns and dilemmas that come up with aging parents and other older loved ones, like what to do if you're worried about falls or safety or memory or even the quality of an older person's healthcare. For today's episode, I've invited a special guest expert to talk about a topic that is really important in my line of work, which is new developments in the treatment of Alzheimer's disease, such as the anti-amyloid drugs Lecanemab, brand name Leqembi, and Donanemab, brand name Kisunla. My guest today is Dr. Jason Karlawish. He is a board-certified geriatrician and professor of medicine, neurology, and medical ethics and health policy at the University of Pennsylvania School of Medicine. He is also the co-director of the Penn Memory Center and the author of the book, The Problem of Alzheimer's. So, Dr. Jason, welcome to the show. Thank you so much for being here.
Thank you, Leslie. It's a pleasure to be here. I look forward to this conversation.
So, I want to talk about these new medications that have become available. It's an exciting development in the treatment of Alzheimer's and dementia. But before we do that, I thought we might maybe start by just addressing the difference or the relationship between the terms Alzheimer's and dementia, because I have found over the years, and you've probably encountered this as well, that people are often a little bit confused about how they relate to each other. So I'm just wondering, how do you generally explain this to people?
Yeah, dementia describes disabling cognitive impairments. So a person who is living with dementia is living with problems with memory, attention, concentration, language, spatial function, some combination of those. And those cognitive problems are causing difficulties performing usual and everyday activities like organizing a meal, traveling outside the home, paying bills. In a word, they're causing disability. So it's a disability caused by a cognitive problem, not by a physical problem like a sclerosed knee and whatnot. So that's dementia. So it describes an illness state in a person. And then Alzheimer's disease is one of the diseases that causes dementia. And it's one of the diseases in the category of diseases we call neurodegenerative diseases. Quirky term perhaps, but it describes how neurons are degenerating, dying. And Alzheimer's is one of those diseases. Another neurodegenerative disease is Lewy body disease, very separate, distinct pathology, but the result in an individual who has Lewy body disease pathology is they can develop dementia.
No, thanks so much for sharing that. I find that I explain this a lot to people. I actually have a video going over it. But one of the things I think about is how there's been this sort of difference in how we approach things clinically and how we might approach things in other ways. And I often tell people that dementia is kind of what we see from the outside. These sort of symptoms, cognitive symptoms that are being caused by some kind of ongoing problem with the brain. And then there's what's happening on the inside that has created this, and that in normal day-to-day clinical work, we often don't have that view into the inside, especially those who are just
not until recently.
Not until recently, right? This is why this is like an interesting development.
It's not interesting. It's revolutionary.
It's revolutionary.
I don't use the word revolution lightly. In science, we probably overuse it. Everyone's discovery is a revolution. But not until terribly long ago, frankly, you had to die until I could tell you what disease was causing your dementia, because the neuropathologist would look at the brain under the microscope and he or she would tell me what was going on. And sadly, of course, the patient was dead, but that's all changed.
Right. But yes, so I did an episode not too long ago on common types of dementia, especially in older adults, the ones who are over age 80. And so we know that Alzheimer's is a certain kind of neurodegeneration, generally starting 20 years before people have really obvious symptoms. Lewy body is another type, vascular changes another type. There are even other ones that we're discovering. And we also know that especially as people get into their 80s, they often have a mix, right?
Yeah, it's what's called co-pathology. It's kind of a quirky term. Is more the norm than the exception in brains examined in people who have dementia, meaning you'll see changes of Alzheimer's pathology You'll see changes of Lewy body. And then a third disease, particularly in the those over 80, which is increasingly more recognized, called LATE, which is a quirky acronym for limbic associated age-related TEP encephalopathy. I didn't make it up. It's an awkward one, but it's a distinct separate pathology. I just got an autopsy report back on a patient of mine recently who had Alzheimer's changes and synuclein changes. And I've certainly seen people have the three changes. And that has a lot of implications for judging the efficacy of therapies and the conversation you're going to have with patients and family members about therapy, because the therapies we have now target just one of those diseases and only one of the pathologies. And so with co-pathology, what you're looking at is additional causes for cognitive impairment that might not be treated by the treatment that we're giving people. We can't say they're not being treated by it, but a skeptic should occupy the position of, until we show it is treating those diseases, we don't know.
Right. And that's why I wanted to start with that, because I feel like for a long time, we could, sort of conflate Alzheimer's and dementia. Alzheimer's, is the most common underlying cause of dementia, especially as it gets into the people that I'm helping. They tend to have more, but now...
There's a useful historical story there, which was by the late 70s, early 80s, when the problem of dementia began to be recognized as something medicine should care about, and not just
old age.
Right. It is something that's seen with aging, and you could call it part of aging. You could, but if you don't like what's happening to a person who has dementia, as that person or the person who cares about them, branding it as a disease, excuse the language, but helps organized medicine to do something about it. And in the late 70s, early 80s, the majority of the limited science that had been done, limited simply because of the number of people working in the space was quite limited, suggested that these many people with senility had amyloid plaques. They weren't yet described as amyloid. Yeah, they were described as amyloid. They hadn't been sequenced yet. And so it looked like everyone had Alzheimer's, and yet most clinicians in that space, a small cadre, could tell you they were seeing different clinical presentations. But Alzheimer's worked as this umbrella term. Secondly, for a long time, in fact, when I trained, and I suspect when you did, you didn't diagnose someone with Alzheimer's until they had dementia. So, in other words, prior to dementia, we just said, well, it's aging, maybe it's the earliest signs, we don't know. And a lot of that was
because mild cognitive impairment.
That's right.
The intermediate
mild
stage,
cognitive impairment,
which could be caused by any number of things, some of which
could
resolve,
be dementia, right?
But also could be the very earliest stage of your neurodegeneration starting to
right.
Cause
if you look
symptoms.
at the first paper that was written on MCI, there were prior papers, but the paper that really made the term enter the medical lexicon was published in 1999 in Then Archives of Neurology. And it described people who were normal, MCI, or Alzheimer's. So that linguistic trope, your listeners, viewers may be like, wait. So to juxtapose MCI with Alzheimer's is a mistake. It should be MCI versus dementia. But remember, at that time, in order to have Alzheimer's, you had to have dementia. You couldn't diagnose Alzheimer's in someone who didn't have dementia. That was the way we thought. And it was a sensible way of thinking. And so MCI was this prodrome to dementia, but since dementia and Alzheimer's were like this, it was a prodrome to dementia. Of course, all that's changed, and now you have this weird like MCI versus Alzheimer's distinction, which actually makes no sense conceptually.
Right. Well, before we go into the treatment of Alzheimer's, maybe you can speak to how we are now diagnosing Alzheimer's, in these more informed times.
At say the Penn Memory Center, we've gone in a short amount of time from a practice that really resembled what Alois Alzheimer's did in 1903 when he met August Dieter, brought in by her husband Carl Dieter, the case that would lead to the case report, which is often credited as the sort of first case of Alzheimer's disease.
I want to specify she was young. Wasn't she?
She was, that's right. In fact, that's why he wrote his case report, because for all intents, she was like, her clinical presentation was like someone who was, quote, senile, had senile.
Right. She was in her
but she was
50s,
only
right?
58. And
Yes.
his point was, how is it that someone who's not yet elderly can have this disease that we see in people who have this problem that we see in the senile, which is aging, but she's not
Right.
aging
Right.
yet. And that's what he actually posited, that I don't think senility is aging because of people like August Dieter, who he looked out under the microscope and saw these plaques and tangles. But
After
that
she was
got
dead.
forgotten and lost in history. Anyway, up until very recently, what he did with August Dieter was what I did is what he did, which is a careful history and interview with the patient and the family member and a neurological exam and a couple tests to make sure they didn't have other diseases. In his time, syphilis, of course, was one of the common ones they had to exclude. Anyway, I still do all that. I do more sophisticated cognitive testing than he did because they didn't have concepts of normative testing back then, which is very interesting. Psychology was a nascent discipline. There was no concept of normal cognition measurement. It just didn't exist. Anyway, but what's been added to my armamentarium now is the ability to use what are called biomarker tests. And biomarker is a term that describes a measure of the physiologic activity of a disease. And I can measure now both of the pathologies that a neuropathologist says lead to neurodegeneration caused by Alzheimer's, namely beta amyloid plaques and hyperphosphorylated tangles of tau protein. And I can measure them using blood tests, spinal fluid tests, and imaging tests. Not all of them are available, et cetera. But I can now tell someone with reasonable certainty that Alzheimer's is contributing, because there could be other diseases I can't measure, but is one contribution of either their mild cognitive impairment or their dementia. Or I can tell them it isn't. And I've actually undiagnosed several people who I have labeled with Alzheimer's, but now they have TDP disease. They have late. I've had several undiagnosed cases recently. And that is truly revolutionary. It has changed what happens at the Penn Memory Center.
Yeah, yeah. So, it's just like so fascinating. And so I feel like certainly since I started medical school, there has been this shift where, yes, when I was in medical school, it's like Alzheimer's and dementia kind of together. Once people have symptoms that are bad enough to be interfering with independence and daily life activities. And I think even then, we knew that the changes in the brain of Alzheimer's that lead to that dementia were starting years before. But now we have a way to detect the presence of the amyloid, the tau, well before. And so now we know that, Alzheimer's disease itself is this process where the brain starts to develop these changes, accumulate these products 15 to 20 years before people have obvious symptoms, slowly accumulating, neurons becoming dysfunctional and dying. And so we now have these.
We did know that, but we were a little skeptical. And I think some still are. I mean, I think there were enough brains of people who died cognitively unimpaired with amyloid that we said, well, how could amyloid be the cause if someone has a head full of amyloid and yet they didn't have dementia? And just those were the times.
Yeah, those were times.
The measures of tau weren't yet in place, although you could certainly count tangles. And so there was skepticism about, is amyloid the actor here? Is it tau? Is it neurofibrillary tangles? Is it something else? I'm not saying that that's settled now. I think the imaging advances and whatnot to follow people longitudinally are better explaining the natural history. And these drugs are also certainly providing causal evidence that amyloid has a role in neurodegeneration. But you could find reasonably smart people in the 80s and 90s who argued, it's not clear to me that amyloid actually is what's going on here. And so anyway, that's all begun to change because of these biomarker measures have allowed us to follow people for decades. And then the results of these clinical trials with Donanemab and Lecanemab are experiments that show that amyloid is a causal actor in the cascade of neurodegeneration that we call Alzheimer's.
Right. Yeah, so we're really understanding now the way Alzheimer's disease develops, but from a sort of diagnosis perspective, now we can diagnose, especially people like you, harder for people just in the field like me, but we can diagnose people with preclinical Alzheimer's, meaning they are showing biomarker changes, right? We can diagnose them.
And yeah, so the preclinical concept, I think, is still not yet ready for prime time. I think it'll be ready potentially in about, I'll be frank, probably 2-3 years. because
But
I
it's something
think,
that exists in people. We know that some people
well,
are in that
conceptually it
stage.
exists. Conceptually it
Okay.
exists. That's right.
Okay.
Conceptually, like almost
Conceptually,
a
that
premise.
exists.
As a premise, I
And
can say that Alzheimer's exists before someone is ill, but I don't yet have the confidence that I can take Mr. Smith and tell him you do or don't have preclinical Alzheimer's.
okay.
I think
All right.
I think if Mr. Smith had amyloid and tau, particularly tau beyond Brock levels of Brock 3, which is a staging thing named after a person named Brock.
Uh-huh. Uh-huh.
Um, anyway, I might say, look, you've got Alzheimer's changes in your brain. I'm less confident that amyloid alone has been shown, amyloid alone, that is the beginning of Alzheimer's. I think that
Okay.
is still something we're working on, and we'll see what the results of the clinical trials are that'll end in 2-3 years that are testing that.
Okay. But we do have a preclinical stage where there are
Mhm.
changes, but people are
Conceptually, we
not
do. Yep.
having symptoms. And
Mhm.
we're assuming that they're kind of progressing and that eventually people get to the point where they're having mild symptoms that would fall
Mhm.
into the category of mild cognitive impairments due to,
Right?
and if you
Inefficiencies in
identify
daily life.
those,
Yep.
and if you identify those biomarkers in there, we might say mild cognitive impairment due to Alzheimer's disease.
Right.
And then as the difficulties progress and get to the point where you are actually not able to do some of the daily life
You need
tasks or work
assistance.
tasks
Exactly.
that you
Yep.
did before independently, now we are at, mild or early dementia due to Alzheimer's disease.
I would call it, mild stage dementia. That stage is being mild, moderate, severe, profound,
Uh-huh.
terminal, the staging criteria. Actually, I've looked at them. They, depending on the same word, describes somewhat different things. When you look at
I know. People tell me my parent has severe Alzheimer's because the person cannot remember anything, but they're like talking, walking, and I'm like, yes. In
yeah.
geriatrics, we wouldn't call that severe, right? I mean, to
Well,
me, severe
we
is
wouldn't. I think it's interesting.
it's
The staging
severe memory
criteria,
loss.
the staging
hmm
criteria. If you look at them, what are they
hmm
normed against? Becomes an interesting question. Survival
hmm
time, and also putting together the compendium of functional and cognitive problems. Most
mm
staging criteria do that. So
hmm
it's impairments in instrumental and basic activities together with the severity of the cognitive problems that sort of niche someone into a stage. And this is
hmm
important. These two doctors having this discussion of staging, this is so boring. Number one, I
No,
think families care
different
about what,
medications are FDA approved for
right.
different stages.
Exactly.
Yes.
That's so families have always cared about what stage is my relative
hmm
because, in fact, the book "Oh Hello Alzheimer's" by Lisa Marshall, she pays very careful attention in her book. So in her book "Oh Hello Alzheimer's," Lisa Marshall pays very careful attention to what stage is her husband and really follows it because for her, each stage means that we're getting closer to the end. But anyway, families always
mm
care about stage, but
uh
even and to add to the importance of staging is these drugs are tested within a range of stage
uh
and prescribed, therefore, within these stage ranges. And so we're creating this concept that there are these stages that are clinically important because if you're in the stage, you get the drug. If you're not in the stage, you don't get the drug. And that's important.
Mhm. Very, very important. Well, my own sort of, generally off the cuff has been that I say mild to moderate when people are having mostly difficulty with IADLs, instrumental activities of daily living, which are very
hmm
cognitive. Generally mobile unless they are having other, health problems.
Yeah, like
Generally
bad
talking,
arthritis or,
although it may not make sense. Moderate is when, the speech starts to become like more limited and they start to have, and or start to have more difficulty with activities of daily living. And then severe is people who, are not talking, are chair-bound or bed-bound, and are saying very little. And I find that families often don't realize that it actually might get to that point, and that we still
yeah,
might have some time
I
to
would
go.
be careful with the use of of aphasia as part of staging.
That's
Um,
true. Some
because I
people, it
think,
can be very variable.
well, depending on the phenotype, I mean, Alzheimer's
Mm,
has 4 phenotype presentations: amnestic, aphasic, visuospatial, and dysexecutive. And in people who have a dysexecutive or spatial variant, language is fairly well preserved for many of them. In contrast, people who have the logopenic aphasic variant, early on, they'll have troubles with language, and language will become a notable problem, such that if you met them and talked with them, and that's all, you'd be like, gosh, this person is so impaired. And you test them and they do horrible on testing because the tests are so language based. But then the family's like, well, yesterday she made a sandwich and, volunteered at the church fair and, really enjoyed the family picnic, and what it is you're seeing the problem with the aphasia. I have a patient with PPA. That's what we call primary progressive aphasia. She's panicked about what it will be like to lose speech. She's very clear about that. It's absolutely frightening. Yeah.
Yes. Well, yes. Well, let's agree that as neurodegeneration progresses, generally people will reach a stage where they're not talking and not walking or moving.
They can, yeah, particularly not talking, and the functional impairments related to bathing, dressing, grooming, feeding, and mobility will, for many, is a common descriptor of many of these diseases in their severe terminal stage.
In their severe stage, right? Okay. So we are going to talk about these newer medications that are available, but maybe really briefly we can talk about the drug treatments that were available until just a few years ago that were the mainstay of what was available to prescribe. We don't have to go into super detail on them. I'm going to do a video just on those, but if you could just sort of briefly summarize what we had
the
until recently.
inhibitors, were first approved in the late 80s, early 90s, and they increased levels of a neurotransmitter called acetylcholine, and in some patients it could produce a noticeable improvement in attention concentration, and to some degree, therefore, in function in a global assessment. In some patients, it was simply not perceived. The curves of individuals on drug versus placebo never diverged. So you had this sort of bump up of performance that kind of maintained in a parallel structure. That's important because if the bump up occurred and then the spread occurred, it would suggest that you're changing the rate of the progression of decline. That takes us to the new medicines. The other medicine is Namenda. Memantine is how it's marketed. Has a similar effect on different neurotransmitters. And again, in some patients, these can cause an improvement in symptoms. There's some data about a diminishment of some of the problems with social cognition, behaviors, et cetera. And they've been available, as I say, since, the first one that was most easily prescribed was donepezil, and that was approved around 1990.
Brand name Aricept. Lots of people have heard of it.
Around like 1993, 1994. Anyway, that was what we had until a year ago, July, when FDA approved Lecanemab with full approval as safe and effective. And then a year later approved Donanemab as well with full approval, meaning not accelerated conditional approval, which they had done with another drug called Aducanumab.
Yeah, so maybe we can actually start with Aducanumab, because that, was, I think, the first one to certainly be in the media. It was approved by the FDA in 2021, although it's been withdrawn this year by the manufacturer. So maybe you can take us through just like briefly the history of
Aducanumab,
these drugs coming out and what has happened.
and Donanemab, all probably you think there must be something similar to them because they seem to have this common end stem of MAB, which is from monoclonal antibody. And there are three examples of actually several monoclonal antibodies that were developed since the early 2000s.
And they all target some version of amyloid, right?
That's right. They go into after amyloid. They essentially exploit the immune mechanism of binding an antibody to amyloid, because amyloid's a protein, and clearing it. And that was the theory. It was elegant in mice, and the studies in humans were very fraught. In the early days, actually, what we found, we didn't have the test for amyloid widely available in the trials, and so we would discover later, like with the bapineuzumab trials, that many of the people that were in the trials didn't have amyloid, so they shouldn't have been studied.
Right. So they were cognitively impaired, but it wasn't due to Alzheimer's pathology.
Yeah. TDP disease, Lewy body disease, etc. So vasculars, et cetera. So you could go back to some of those drugs even and consider revisiting them. The problem with the drugs is a side effect that became evident early on, which is they can cause microscopic bleeds in the brain, which if not detected can lead to swelling and edema, and which if not detected and intervened on can be deadly. And so some of the early drugs had to be halted because of that side effect. And we just didn't have the technologies to detect it weren't as well developed, namely MRI technologies, et cetera. All of this to say that it was a bit of a rocky road developing the drugs. And then Aducanumab comes along. Aducanumab really was the first one to really use biomarker testing, namely PET scanning, to be sensitive to issues of microscopic bleeds and swelling, and even to recognize that there was a genotype that increased your risk of it. So they had a lot of stuff aligned. The problem was Biogen, the company, over time began to change the design of the trial, the conduct of the trial. Even at one point, they lost a lot of their scientific staff over in protest. The head of their DSMB, the stats group, the head of their stats group left, the advisory group. I mean, it's a bit of a, so that they did an interim analysis of these two studies which showed mixed results, more data. The bottom line was what ensued was a failure of regulatory science.
I see.
That's what happened. The FDA entered into a relationship with Biogen, which led to a host of decisions that at the time and in retrospect were simply bad decisions. And it led to a congressional report even that produced that. So the drug really had a faulty entry into the marketplace.
Well, I remember it was quite controversial when it was approved,
Well, right, because it was approved
Yeah.
with this series of decisions that FDA made in cooperation with Biogen that were bad decisions. They were just bad regulatory science. And having said that, the drug actually may work. We just don't have the data to show it, given the data that Biogen produced and that FDA allowed to make it into to get a label. But the label, and just to wrap it up, was not full approval, but what's called conditional approval. Namely, they approved the drug only on the basis of the ability to lower amyloid, required further study to validate that. And for many in the field, and I'm of this view, I think we haven't yet arrived at, at the solid data to say that amyloid is a surrogate, like LDL cholesterol is a surrogate endpoint, or hypertension, because we actually don't know what amyloid we're measuring, what amyloid is actually the marker that the disease is being treated. And that's a really important point.
Okay. So did you ever use Aducanumab at the Penn Memory Center?
It never made the formulary.
Okay. So let's now move on to the newer ones that have been approved. Lecanemab approved in 2023, and then Donanemab approved just this past summer in 2024. Tell us a bit about these drugs, how they work.
These are monoclonal antibodies, and they both target amyloid, but they differ in what they target. And this is why amyloid as a surrogate, I think, still is a work in progress. Namely, if saying that someone is benefiting from the drug if amyloid is lowered, because when we measure lowering of amyloid by PET scan, we're measuring the neuritic plaques in the brain, and that's what Donanemab targets. It actually targets the plaques and removes them. In contrast, Lecanemab actually targets the oligomers, which are protofibrils that lead up to a plaque. And so it's removing oligomers, which manifests itself as the plaques don't accumulate. But it's not clear to us, what measure of amyloid is the sign that a drug is working? And so that's why I think we're not yet at the point where we can say lowering amyloid alone is good enough to approve a drug, although FDA still holds to that. So Lecanemab targets these toxic oligomers, and the result in one, and they only did one, FDA allowed them to do that. We could debate whether that's appropriate rather than two randomized controlled trials, but it was a well-designed randomized controlled trial, which was conducted in a perfectly acceptable, responsible way. Led to was a completed data set, not an interim analysis. And it showed that the drug, people on drug had less decline on measures of cognition, function, combination measures of those. And generally the trend in biomarker measures showed a reduction in the biomarkers that followed the direction with which you would say the disease is not progressing. Donanemab had the same results, different measures. They used different scales in some cases, but the same theme of the results was there. One finding that's often noted with both drugs is that people on drug had actually more brain shrinkage than people off drug on placebo. And actually, Nick Fox at University College London has done a very thoughtful analysis of that. And what it probably reflects is the clearance of the amyloid is reducing brain volume because there's not as much amyloid there. So as amyloid contributes to brain volume. So when you're seeing atrophy, what you're probably seeing that these drugs are causing, it's not atrophy. What it is the amyloid, loss of the amyloid load in the brain.
Right.
But that's what both drugs do.
Yeah. Well, I know you and your colleague, David Wolk, I think, at the Penn Memory Center.
With me.
Yeah. That the two of you recorded a really great video and presentation explaining those two studies in depth. I'm definitely going to link to it in the show notes for anyone who wants to look at it in more depth. But you were saying, people didn't decline as much on these drugs, right? And can you speak a little bit to like how big an effect is this, right? So in sort of practical terms, like what does this look like, for people
so the two ways
who took
that
it?
I think I can translate the cryptic language of how we talk about and measure Alzheimer's dementia or mild cognitive impairment into something that is, I think, more coherent to patients and family members is there's two ways. One is after a year and a half of being on this drug, I slow things down by about 6 months. That's one way to think about it. So, you could say,
so people are
that
still
means after
declining.
18 months, I've only gone 12 months of disease course compared to had I been not on the drug. And that's one way to look at it. Yeah.
So it sounds like a lot of people on the drug still declined, just not as quickly as the people who are off the drug. And so it was
on placebo. That's right. Yeah.
And they were kind of like
it's a little quirky
6 months less
like,
of decline.
Okay, so over a year and a half, actually, it won't be a year and a half of disease. It'll only be a year of disease progression. And like, it's kind of a conceptual thing, like, well, but 18 months of chronologic time has passed, but only 12 months of disease time has passed in some sense. That's one way to look at it. So
it's like people slowly get worse, but you won't get as far worse.
Right. These are very slowly progressive diseses, but there's a lot of variability, and a lot of that relates to comorbidities, vascular disease, also this co-pathology that we talked about.
Okay.
Plus the drugs, the drugs are only so effective, I suppose, is what we can conclude as well. That's again something that will be worked out with further studies. Is this the limit of this drug's effectiveness? Or is it, for example, the fact that drugs require enormous amounts of drug being given to get into brain? And there are newer formulations of these drugs, this antibody drugs, where less dose needs to be given, number one, and there's greater penetration into brain.
Right.
And those are we'll see what those drugs do, because they are less likely to have the body produce antibodies to the drug, which is one of the limiting issues. The body starts to clean up the drug, and there's more penetration into the brain. So those studies are ongoing. There's a couple of drugs under study right now that have that promise. Anyway,
so what's the second way that you kind of conceive of?
The second way to talk about the benefit is after 18 months, if you're just on placebo, or after 18 months of no treatment, about 30% of people with either MCI or mild stage dementia progress to the next stage. They go from MCI to mild stage. They go from mild to moderate. About 30%, 70% don't. If you're on the drug, you reduce that to about 20%.
Okay, so is that like a number needed to treat of 10?
Well, it's not an NT, it's just an absolute risk reduction, going from 30 to 20. You could do it as a relative risk, and then it's about a 40% relative risk reduction. I can't do the ratio in my head. But anyway, so I kind of like that one because people do think in stages. This gets back to our conversation about stage. What is my stage? And so that's another way to think about the drug's effect. The key message
I was thinking number needed to treat because these are, quite expensive drugs right now, right? So if people are thinking,
they're in the high 20s with other fees and whatnot. They probably go a little higher, and depending on a copay, a patient could be out of pocket for a couple $1,000s potentially.
Yeah. So to spend all this sort of what is, what is the likelihood that you'll avoid going into a next stage? Although one thing that I was wondering about, I haven't looked at the data in depth, is when you see that people who are on the drug are declining in a way more slowly, right?
That's what the trials show.
When they look at individuals, is it that some individuals are declining a lot less slowly and some individuals it's not making a difference? Or is
Well,
it
there's
that,
certainly variability.
in
And
most people,
the
like they're all
Donanemab,
kind of declining less?
there's variability. And I think
Mm-hmm.
copathology is one of the
Uh-huh.
reasons why. There's the data from the Donanemab studies suggest that the tau burden that the person has, the amount of tau protein, which is the other pathology seen in Alzheimer's,
Mm-hmm.
that has an influence on the efficacy of the drug. Namely, individuals with a low tau burden have a greater response to the drug than people with a high tau burden.
Mm-hmm.
And this has led to an emerging idea that there's a stage of tau burden, which might be a stage at which, at least for these drugs, they're not effective.
Mm-hmm.
That becomes very interesting because the Lecanemab study lasted 18 months and didn't end. In other words, they just stopped the study at 18 months and analyzed the data. This is important. In contrast, the Donanemab study measured amyloid repeatedly, and when it was cleared below a value that they could measure, which is just for
Mm-hmm.
the sake of naming it called centiloid, when they
Mm-hmm.
went below a centiloid cutoff, they stopped the drug.
Mm-hmm. Right.
That's attractive clinically. There's a certain logic to it as well. So Donanemab basically says, give me the drug. I mean, that drug doesn't say this, but with Donanemab, you get the drug, you repeat amyloid after a certain amount of time. If it's below the centiloid, you stop the drug.
And those people
Lecanemab,
continued to do better too, right? In the study.
yes, that's the open label extension data suggested that.
Mm-hmm.
The Lecanemab study was give the drug for 18 months and it didn't have a stopping rule.
Right.
Now the
Right.
company has done modeling data, which means
Mm-hmm.
extrapolating from data, not observing actual people, to suggest the value of continued dosing
Mm-hmm.
at a lower dose.
Right.
I think the field is still scratching its head about what to do. And
Mm-hmm.
this becomes not just clinically, but frankly, ethically charged because, if someone's continuing to progress and they're on their Lecanemab, of course, it's a choice about whether they still want to be on the drug, but it is a choice because the way the drug is prescribed is that you're on it until you don't want to be on it, unlike Donanemab, which is we'll clear the amyloid and then we stop the drug.
Mm-hmm.
So
Right.
I think there's going to be some real struggles with decisions, is it worth staying on this drug? And I've had some of my patients like, why am I still, I'm getting worse. I don't think I should be on this. And then the
Uh-huh.
debate is, well, but you could have been getting worse quicker off of it. So really the
And we
question
don't
is,
quite know what will happen once they stop it either, really.
yeah, the deeper question is you may be getting worse, but is this state of worseness one that you don't want to treat anymore? And I think
Mm.
I'm seeing patients struggle with that and some not. Some are quite content to stay on the drug.
Mm-hmm, mm-hmm. Well, yeah, can you speak, well, actually, I would love to hear more about your experience actually having patients on these drugs, but really briefly, while we're still finishing talking about the studies for this, can we talk really briefly about who was in the studies in terms of like age, stage of Alzheimer's, because that's always really
Yeah,
important
so
when considering
to
the
be enrolled
results
in the
of
studies, you
trials.
had to have evidence of amyloid
Mm-hmm.
and you had to be at a stage of mild cognitive impairment,
Mm-hmm.
which is cognitive problems causing inefficiencies in daily activity, or mild stage dementia, which is disabilities in instrumental activities of daily living were kind of the hallmark.
Mm-hmm.
And so that was the window. People also had to have a mini mental state exam score that was above, don't quote me, but like 20 or
I
both
think it was
studies
20 or
has.
22, depending on which study it was. Yeah.
Lecanemab had a higher one. It was 22, and
Uh-huh.
I think Donanemab was 20. I could be
20,
wrong.
yeah. Mm-hmm.
The populations were slightly sick, more advanced than the Donanemab study. So that's the population, and my colleagues and I
And I think
generally.
in Donanemab, mid-70s, right? Something
Oh,
like
so
that?
age-wise, the average age was in the 70s. Yep.
Yeah, yeah. Which
Yeah.
is relevant to me because in the work I'm doing right now with people helping their aging parents, a lot of people are helping parents who are in their late 80s or
Hmm.
early 90s or mid 90s, starting to deal with dementia. And,
Yeah, I think
this is coming up. So we have
neither
exciting
label has
data, but
an age restriction
of
on it,
course.
and I don't see prima facie a reason that someone who's 80 or 90 can't get the drug. In other words, based on their age, just that alone. Now you could say, well, they're 80 and they have notable frailty, et cetera.
Well,
And for those reasons,
they're more likely to have mixed pathology.
that's
first
right.
of all.
That's right. So that's part of a
One.
conversation about what's the benefit for you.
Right.
So I could see someone with mild stage dementia, 85 years of age, E4 carrier, which means higher risk of bleeding with the ApoE4 gene. And so, given that risk probability, given the comorbidity pathology, given the state, you're at the end of mild stage dementia, the balance of benefit is really quite low compared to the chance of risk. It's less attractive compared to someone in the MCI stage, with no evidence of concomitant pathology in brain, et cetera. E4 non-carrier, they have a different risk-benefit profile, I think.
But from the data we have right now, did they study enough people who are, say, 90 for us to have a sense of how well it works in people?
Yeah, well, I don't think we have enough data on any age group. To me, the age group that we don't have enough data on any age group to make firm conclusions. I mean, about any age group benefiting or not. I realized Lecanemab did these forest plots, which showed that I think people in Europe didn't benefit because it crossed over the identity line, and women didn't benefit. And people look to that and say, so look, the drug doesn't work for women. Well, it doesn't also work for people in Europe and whatnot. But the point of a forest plot is not to conclude significant, non-significant for the groups that you create trees out of to make your forest. It's to say, do you see across the forest, are all the trees blowing in the same direction of the wind? Excuse the metaphor. And the forest plots generally showed that granted, some of the lines crossed identity, but you didn't see, like, for men, there's this benefit, but for women, they're way over here, completely not, harmful. And you didn't see a forest plot where things were on either side of identity, trees blowing in a hurricane all over or whatever. You saw everything favoring a drug greater than placebo, with the exception of a few things touching identity line. And that was the women and people who were over whatever, and people who lived in Europe. And, if I found people looked at that forest plot, and if they didn't like the drug, they would just look at the forest plot and say, well, see, it doesn't work for women. We shouldn't approve it.
Okay.
It's like, oh, come on. That's, you can do forest plots on any clinical trial, and you're slicing and dicing the data so much that you're going to find
you'll find someone for whom it seems it's
and then you're going to say,
working.
oh, don't give statins to people who live in New Jersey. It's like,
right.
Wait a minute. What are we doing?
So that our viewers don't get confused, was there a suggestion that these drugs work less well in women?
Again, the forest plots showed identity line, and I hope your viewers are going, what the hell is identity line? The forest plots suggested they didn't, but do not look at the forest plots to look at clinical efficacy. That's not what they're for. And it's it would be, I think, inappropriate as a clinician to say these drugs do not work in women and should not be prescribed to women. That would be, I think, inappropriate.
Right. But it is relevant to sort of think, well, when we look just as women, at women, how well does it work? Because we have, for a long time in medicine, we're sort of like, oh, it's working, and the studies were mostly done in men, and then we started making sure that things worked in women because
I think the gender balance in this study
different.
was pretty equal. Yeah.
Okay. Yeah. So tell us now, what's it been like at the Penn Memory Center? Which of these drugs have you used?
A year ago,
November.
We started prescribing a year ago, November 16th. And we're over 100 people infused with Lecanemab. We will soon start Donanemab once it gets going. Our experience very much relies on a couple of infrastructures we put in place. One of them is we have a weekly conference where we review every patient who is brought forth for infusion. It's a multidisciplinary review. All the clinicians who are prescribers, neurology, radiology, neuroradiology, and the clinical infrastructure team. And we discuss each case to review whether it's appropriate to proceed with therapy and to learn, to discuss our experiences. And it is a fascinating learning opportunity to better understand interpreting MRIs for the side effects, thinking through the results of the amyloid testing, whether it's spinal fluid testing, which is what we use a lot of. And we've seen about the same rate of infusion reactions that people get. So fever, chills, achiness, as was seen in the trials. Usually after the third dose, people don't get those. And our experience with the side effects of the microscopic brain bleeds and swelling is pretty much the same as the trials in terms of frequency, if not a little less. And we are infusing individuals who have 2 copies of the ApoE4 gene, who are at the highest risk of having those microscopic bleeds and hemorrhages. Our stopping rate of people who had to stop drug is low, but a few people have had to stop because of the side effects. And the others who have had the side effects, it's been pauses in infusion or a few people needed steroid treatment and whatnot too.
Does it seem to be helping as best you can tell?
Well, that's where you're left with an enigma because you don't know the counterfactual for the individual.
Right.
I don't know the counterfactual for an individual. How would you have done if you weren't on this drug? Kind of what you're left with is waiting for some biological measure that we could say with confidence says the disease process has been slowed down. That would be nice. A measure of neurodegeneration, neurogranulin. I'm not sure what it would be.
Are you following amyloid? I'm sorry, in these patients, or?
So everyone in the study, everyone in this who are getting infused are in a study. We've set up a cohort study where we follow up with serial MRIs beyond those safety MRIs and blood. So that'll allow us to reassess some of the biomarkers. We'd like to build in follow-up measures of amyloid PET and tau and whatnot. That's to be determined. We're also studying the experience. So we have an interview study going. We've interviewed all of the clinicians around their experience with these drugs to better understand how they go about working with a patient and family to decide whether to take the treatment. And then we're interviewing patients and caregivers who choose to take the drug and who choose not to take the drug to better understand why they make those decisions. And then we'll go back and re-interview them about a year later. So we're taking a very evidence-gathering, open-minded approach to learning from our experience with these drugs through doing observational studies.
Yeah. Now you are at a renowned, well-established memory center.
Well, thank you.
But many people might get this drug not at such a center. But if I remember right, Medicare did say that people have to get it from a clinician who's participating in a qualified registry, right?
Yep.
And has an appropriate team. So what's your sense of how, for people who are not getting it at a really research-oriented, memory center like Penn Memory Center?
I don't know.
Do you have a sense of what the experience is that other people are getting?
I don't have a sense. I am worried. Not that I'm saying we're great and they're bad, but these are complicated drugs. And there's a lot of steps along the way with which mistakes can be made. Just to begin with, we don't even have an infrastructure of Alzheimer's specialists. If you think about it, anyone could prescribe these drugs. I mean, there's no such thing as an Alzheimer's specialist because you did a certain amount of training.
I think Medicare, well, that's true, but I think Medicare is saying that they at least have to have the infrastructure to have enrolled in like the registry and have some kind of team, right?
Yeah.
Although I don't know how closely Medicare is looking at that, but that means your
I can't
garden
imagine
variety neurologists, I don't think can necessarily.
But I mean, in some sense, if you've got an infusion center, because I don't know, you infuse anti-neuroinflammatory drugs,
you could start doing
gamma
this.
globulin. If you've got an infusion center, you could give these drugs. You may have never diagnosed Alzheimer's in your life. I have had one, now I'm being doc anecdote, but I have had one patient who was worked up and essentially, it was a decent clinical workup. And that went straight to an amyloid PET scan that was positive, and the doctor called up the patient on the phone and said, "You've got Alzheimer's. Your test is positive. There's an infusion treatment. If you're interested in it, let me know." And that was the end of the phone call. And they were just devastated on a number of levels. The way the diagnosis was delivered, the fact that there was nothing else other than just there's this therapy if you want it.
Right.
And what we are finding is that it's a very interesting observation of the sociology of medicine as a profession, that there's a lot of interest now in going into our field. We're finding residents and fellows are showing up, which is fabulous. I am not complaining.
Going into the field of neurology,
they want to work in a memory center.
geriatrics,
They want to work in a memory
center.
Yeah, whether they're geriatricians, neurologists, psychiatrists. Yeah, no, it's great. It's great.
Yeah.
I'm not complaining.
No.
But for some of them, it's all about whether someone can get the drug. In other words, like they work a patient up and like, I don't think she's a candidate for Lecanemab. And say, well, what do you think she has? I don't know. So, it's funny how the drug is driving practice to the point that like we're supposed to make a diagnosis here, even if you don't think they can get Lecanemab or Donanemab.
Right. And we're supposed to help them with the practical things that they greatly care about.
Yes.
And so let me now ask you about some of the things that I'm routinely asked about. Maybe you can speak to how these drugs may or may not help with this. Well, first, very quickly, coming back to the mixed dementia issue, right? Which, my presumption is that that's what people have when they're, certainly above age 85. What do we know so far about the effectiveness of these drugs in people with mixed dementia, or is that still being sorted out with
That's still being
research?
sorted out. Yeah.
Still to be sorted out. Okay. So another thing that is often of huge concern, especially to families, to a lesser extent to the older person with Alzheimer's or another form of dementia themselves, are the behavioral symptoms, right? And, first of all, like families are extremely concerned about the person resisting assistance or getting upset about, their attempts to offer some assistance and support. And then there are people who, as are having delusions or getting very agitated, and are otherwise exhibiting behaviors that, either jeopardize their own safety or create, a lot of stress and challenge for the people who are around them. What do we know right now about how well these medications might help with that? Because generally, when it's come to Alzheimer's medications, in the studies, the metric that they have studied is improvements in cognition, which is important, but often in people's lived experience, especially for families, it is especially those behavioral issues that are a huge driver of their experience. So what do we know about that?
Yeah, the ones, to me, the one bit of data that really, two bits of data in the Lecanemab study stood out that were reported in the supplement that was in the New England Journal paper. One was a patient self-reported measure of quality of life. I don't like that term in this field for reasons I can explain. But essentially, it's a measure that says 13 questions that asks you, how do you feel about your family? Good, very good. How do you feel about your life at home? Very good, good, fair, poor. How do you feel about, so it's about feeling, which is not about, that's quality of mind, not life.
Okay.
And patients reported less decline on that measure over time compared to patients on placebo. And caregivers rated the patient on that same measure. How do you feel about your mother's life at home? How do you feel about? So I thought that was very provocative. And then the other measure was a reduction, a less change and decline in the measure, the Zarit scale for caregiver burden, which was developed by Steve Zarit years ago. And it's a measure of a variety of behaviors in particular that cause caregivers what we call burden. And so we know from the Lecanemab study, and I just don't know if Donanemab measured this. This is just the ignorance on my part.
But there was an improvement on the Zarit burden scale.
It didn't decline as fast as the placebo group. That's right. And the quality of life measure. I thought that was very interesting.
Some other metrics that I know families and also the older person themselves are often very interested in is, will this help me live at home, alone longer, right? I often have people who initially, when they start this journey, are desperately trying to get their parent to take the donepezil brand name Aricept because they think that this will be the thing that allows them to keep living at home for much longer. In my experience, not really, but that's often something that people are looking for.
We don't have those data. I have a hunch someone's going to pop out a study that shows that, and maybe they'll model it. I will say I find the living at home metric problematic. Because I think
I'm not saying it's not problematic. I'm saying it's something that people are often extremely interested in.
Yeah. So we don't have data to say you will live at home longer. We don't. I don't have that.
Well, it's problematic because so many things go into whether somebody can live at home.
Also, there comes a time
Mm-hmm.
when home doesn't work anymore for some
Oh,
patients.
I
It's like the wrong
entirely.
place. It's the
Oh,
wrong
yes,
place
yes.
for
Very
it's the wrong
isolated,
place for the person to live.
especially when they live alone and have dementia, can be quite
Oh, yeah.
isolated and
Yeah.
not getting a lot of what they need.
Yeah.
That's
No, I
true.
mean,
But it's often where they want to be.
I am bothered by how policymakers push the idea of, our goal is to keep people in their homes as
Right,
long as
right.
possible. I understand the rhetorical push there. Our goal is
Mm-hmm.
to keep the patient living in the right place for them for as long as possible. It
Yes.
oftentimes is home,
Mm-hmm.
but oftentimes home is no longer a home for patients. That's the
Right.
problem.
Right. In our last few minutes, we've really focused on these new exciting drugs, but what are other things that you include in and that you think are important for patients and their families to include when it comes to the treatment and management of Alzheimer's and related dementias?
Well, education about the diagnosis, and as they ask and about that, what do they want to know about what to expect in the future? I very much let
Mm-hmm.
them draw. What is it that you would like? They'll say, what should I expect in the future? So what is it that you want to know about? What are you worried about?
Mm-hmm.
So that education around what's the cause, and what to expect in the future, and then education regardless about what to expect in the next 6-12 months.
Mm-hmm.
And then based on that, putting together a plan to provide the necessary support for the patient and for the family member, the
Mm-hmm.
caregiver, to be able
Mm-hmm.
to achieve those goals, to be able to
Mm-hmm.
do that work. Judicious assessment of mood and well-being with attention to anxiety and depression and
Mm-hmm.
loneliness,
Mm-hmm.
and interventions as appropriate to address those problems. And recognition over time that the person in the caregiving role will have a changing role as a supporter for helping the person make decisions,
Mm-hmm.
particularly for people with MCI. I have
Mm-hmm.
one person I follow, not because he's my patient, but he reached out to me as a filmmaker, and he was started on Lecanemab appropriately in terms of the biology of his disease. But the physician who prescribed it made absolutely no effort to say, why don't you bring your partner in?
Mm-hmm.
And no effort to engage that. And the
Mm-hmm.
stunning thing, I think, is that physician would say, well, he was competent. Why did I have to bring her in? And he was
Mm-hmm.
competent. The patient was able to make the decision
Mm-hmm.
to take the treatment. But
Mm-hmm.
to identify someone with a disease that will impair higher cortical function over time, such that this person will need supported decision making, to not, as part of your standard of care, say, who's out there for you and when am I going to
Right.
meet them?
Yes.
I think is actually, I hope becomes viewed as bad medicine.
Mm-hmm. Yeah, yeah, I agree. Well, in closing, any favorite resources that you'd like to share or recommend for
Well,
families who are
alzheimers.gov
dealing with
is a
this?
federally
Mm-hmm.
produced
Mm-hmm.
website that I think really does put together a lot of good information for patients and families. I recommend alzheimers.gov. Everyone should visit the Penn Memory Center website as well, because I think
Mm-hmm.
pennmemorycenter.org really has a lot of great information. But alzheimers.gov is, I think, really a source. And then I'm quite a fan of our podcast, The Age of Aging, because it's a podcast where these kind of conversations and stories are being told about what it's like to live with this disease, make the choice to treat it, and over time, the experience of being in a person on treatment. Those are the kind of stories that we're telling on Age of Aging, a podcast that we've been producing. So take a look at that too. But alzheimers.gov is the best source for information.
Okay, great. Well, thank you once again,
You're welcome,
Dr.
Leslie.
Jason, for being here today with us. Thank you.
Thanks so much. It was great to be here.
So with that, thank you so very much for watching. And if you found this video podcast helpful, if you're here on YouTube, please go ahead and subscribe, as it does help more people find the channel. And if you're someone, again, who is trying to figure out how to help an aging parent, I have a special interest in supporting people like you. So I have created a variety of helping older parents resources and trainings. And I also have a book, When Your Aging Parent Needs Help. So if you'd like to get more useful information on how to care for your aging parents, including the free trainings, please visit betterhealthwhileaging.net/helping-older-parents. And then last but not least, if you've been listening to the audio version of this episode on the podcast feed, please come and take a look at the video if you get a chance. You'll see my key points displayed on the screen. So thank you once again, and I look forward to seeing you all again on a future episode of the Better Health While Aging video podcast.